Okay, so in continuation to our previous emergency medicine series, last week we discussed about breathing difficulty. So now we'll continue about chest pain. So the basics of chest pain is to understand chest pain, you should first understand what are the organs which are within the thoracic cavity. So they are basically the lungs and the pleura, the heart, a part of the gastrointestinal tract with this esophagus, and everything is surrounded by the chest wall, which is the skin, the ribs, and the associated muscles. Okay, so this is just a gross overview. So heart straight away includes everything related to the heart, like the pericardium, the aorta, and the vessels. Okay. So whenever patient complains with chest pain, it can originate from any one of these gross organs. So our aim as a emergency physician or a emergency medicine doctor will be to understand whether uh, pain is originating from any one of these organs, because the assessment and treatment will vary depending upon the cause. But there is yet another way of classification, which Harrison says is, so rather than finding the organ which is causing the pain, it is more important to rule out whether the chest pain is a life-threatening acute condition or whether it is a chronic condition which has worsened recently, or it is a non-life-threatening condition. So this is yet another way of considering. So we should understand both. So based on the anatomy, we can classify what is causing chest pain. I think that is more logical to think and to discuss. But in your emergency medicine approach, how you should go about is whether the chest pain is life-threatening, maybe a chronic condition which can cause life-threatening worsening, or if it's a non-life-threatening condition. For example, myocardial infarction is a life-threatening acute condition. Aortic dissection is a life-threatening acute condition. A chronic condition which is causing a life-threatening complication will be something called a stable angina. It is not an acute condition, but patient comes to the OP with a symptom which is a part of the chronic condition, but it may be life-threatening in future. So this also should be considered. Pneumothorax is also probably life-threatening condition. Non-life-threatening conditions will be just a plain gastritis, esophagitis. Okay, I'm just giving you the examples. So we'll discuss more in future. So your medicine in the casualty should be to identify whether it is a life-threatening, probable life-threatening condition or a non-life-threatening condition. And it can originate from one of the above organs. Okay, so we will straight away go to each type of chest pain. So as I already told you, heart is the major organ causing serious stress to the patients and to the relatives, whether the pain is originating from the heart. So you can classify cardiac cause of chest pain as anginal or non-anginal. So as you know, anginal pain is caused due to reduced blood supply to the heart. So it is a vascular condition. The non-anginal causes of cardiac chest pain can include pericarditic type of chest pain. So pericarditis can also cause type of chest pain, but it will be different. The other one can be okay, so mainly we can discuss these two first. So when to say pain is anginal type? So there are few characteristic features. So at least remember 3 features which can be told as anginal. So one is retrosternal, compressing type of chest pain. So the clinical examination, clinical symptomatology chapters in Harrison, they have changed the chapter name from chest pain to chest discomfort. So most of the time, they never tell it as a pain. They tell it as other sensations. For example, anginal type of pain will be more of compressing in nature. That will be the specific. That will be the word they use rather than a pain. they won't tell. They'll tell only it as a compressing type of pain. So retrosternal compressing type of pain, which is aggravated on exertion. So exertion can be even just walking, or person who is accustomed to walking, running, anything which they are unaccustomed. So retrosternal aggravated on exertion and relieved by rest. There are few other features also. For example, any chest pain associated with sweating, palpitation, or giddiness, that is syncope. If these features are associated, or there is history of risk factors. So last in breathing difficulty class, we are discussing whenever you are approaching any emergency medicine case, a quick assessment should consist of the prior comorbidities, because that will help us to identify what may be the cause of breathing difficulty. Similarly, any patient with hypertension or diabetes or a prior cardiac disease or dyslipidemia, a family history of these things, because now age itself is not a risk factor. Myocardial infarction can occur even at an younger age. So a family history of coronary artery disease itself can be a risk factor to consider MI as a cause, myocardial infarction as a cause of chest pain. So all these are the risk factors which you should ask. So these are the other features. But if at all you have to remember 3 points: retrosternal compressing type of chest pain, aggravated on exertion, relieved on rest. These 3 out of 3 is called as typical anginal chest pain. But in most of the scenarios, these 3 may not be present. For example, patient may tell it is a compressing type of chest pain, but they may tell it is present always. It may not be aggravated on exertion. Some say the pain is present, they feel better on relieving, but it's not aggravated on exertion. So we may get only 2 or 1 of these 3 features. So if 2 out of the 3 feature is present, then we call it as an atypical anginal type of chest pain. So 3 of these 3 is typical anginal, 2 of the 3 is atypical anginal. If none of this is satisfied, or only 1 of these 3 criteria is present, then we call it as a non-anginal or non-cardiac chest pain. So these 3 can help us identify. So if it is a typical anginal chest pain, so mostly the heart is involved. If it is an atypical type of chest pain, then again we should consider heart is the source of the pain. If it is a non-cardiac chest pain, I think we can be a little, not completely satisfied, we can be little satisfied that it could be a non-cardiac chest pain. It can arise either from the lungs or the musculoskeletal or the esophagus, as we have discussed, musculoskeletal or esophagus. Okay, so this is the first step, whether it is an anginal or non-anginal. If it is anginal, typical anginal, atypical anginal, or non-cardiac anginal. So the other type of pain which can originate from the heart is called pericarditic type of chest pain. This type of chest pain is similar to pleuritic type of chest pain. So we'll discuss this along with pleuritis. Okay, so since we have started about cardiac, how to proceed about when the patient is having a chest pain. So the approach to chest pain. So as we already discussed, assume that 60 years male is coming to your casualty with chest pain. So we're asking a quick history. Patient is a known case of diabetes, hypertensive. He's on irregular treatment. So this is his history. So he's giving a chest pain for 6 hours duration, which is continuous. And the pain he told is very typical. So it is compressing type of pain, retrosternal. And he's telling it is that present continuously, but it is little relieved when he's taking rest. And when he's moving or when he's doing some walking or activity, it is increasing. And as the time goes on, his pain is increasing. So he comes in a sweating state. There's some palpitation, there's some giddiness. So straight away, all the 3 criteria are satisfied. So this is a typical anginal type of chest pain. So the source of origin here is the heart, caused due to reduced blood supply to the heart. So there is no doubt on this one. So how will you proceed with this case? So We have just taken 2 minutes to ask the history, check the vitals, and look at him and come to a conclusion. And maybe basic examination is normal. So how will you proceed? So since by history we have come to a conclusion that it could be a cardiac cause, what you do next is do an electrocardiogram. It's a 12-lead standard electrocardiogram. So we may do an X-ray facilities there, but if at all one investigation you have to do in any case of chest pain, and one investigation which you have to do in any case of abdominal pain will always be an ECG. Okay. So we'll just discuss a side note about angina. So when you classify that angina is present, angina can be of two types. One is stable angina. So stable angina is the same thing which we have discussed. It's a typical anginal type of chest pain, which is absent at rest, which is aggravated on exertion. It gets relieved on taking rest. So the patient will not come as an emergency. They may come as an OP basis to assess the cause of chest pain. So stable chest pain mostly goes to the OP setup. It very rarely comes to the emergency. Sometimes they may come to the emergency just by panic. So that is called stable angina. When do you say angina is unstable angina? So again, the pain is anginal type of chest pain. They may give a history of stable angina. But when you tell that angina is unstable, one, there should be pain present even at rest. So I was telling you, if pain is relieved by rest, it is mostly anginal. But when you should be more cautious is the other two features are satisfied, but pain is present even at rest. Second, the pain is crescendo type. So the frequency or the severity of the pain is increasing as the time goes on. That is called crescendo type of pain. So that makes pain unstable. It should not be relieved with nitrates. So usually patients with stable angina, their pain gets relieved on taking rest or taking nitrates. If the pain is not relieved with nitrates, then it is an unstable type of variant. So pain is crescendo in nature. Pain is present even at rest. It is not relieved with nitrates, then it is called unstable angina. So this is also called as acute coronary syndrome. So it remains as unstable angina when ECG is normal, like the pain is typical, but ECG is normal, and cardiac biomarkers. So we send two cardiac biomarkers, troponin T and CPK-MB. There is another troponin which is called as troponin I. Troponin I is preferred in cases of CKD. In CKD, both troponin T and CPK-MB may be falsely elevated. So if the patient is suspected to have chronic kidney disease, then you can send troponin I as the cardiac marker. So if patient is having pain, anginal type of pain, even at rest, not relieved on nitrates, pain is keeping on increasing, then you can suspect that it is unstable angina if ECG and troponin is normal. So the same clinical scenario, if the markers are elevated, the cardiac markers are elevated, and ECG, there are some changes, but it does not show ST elevation. We'll discuss ST elevation shortly. So markers are present without ST elevation, then it is called as NSTEMI. So the same unstable angina, if markers are elevated and ECG shows typical features of ST elevation, then we call it as STEMI. Right? So angina is stable angina and unstable angina. I told you when to tell it is unstable angina. So in any chest pain, we have done an ECG, cardiac biomarkers we have sent. If the markers are elevated, ECG is not showing, markers are not elevated, ECG is not showing any abnormality, it is labeled as unstable angina itself. If the markers are elevated, it becomes myocardial infarction. Plus, you classify myocardial infarction as STEMI or NSTEMI based on ST elevation and NSTEMI. So now you may ask me a question. Is it enough if I diagnose that it is only a cardiac type of chest pain? Why should I take the next effort in looking at an ECG or looking at a biomarker and classifying whether it is unstable angina or STEMI or NSTEMI? It is very important from your side because you would have learned the golden rule: time is muscle, time is heart, time is heart, time is muscle. So every minute you save is going to prevent the patient from going into heart failure in future. So it's not necessary for a cardiologist or a physician to interpret an ECG and take the next steps. Even if you are in a low resource setting, most of the low resource settings will have an ECG. So you can do that ECG. Even if biomarkers are not available, at least you can do an ECG and pick up ST elevation so that you can decide on treatment. So before telling about the basics of ECG and biomarkers, I'll just tell you what is the gross treatment. If the patient is having ST elevation myocardial infarction, the preferred treatment is PCI, percutaneous coronary intervention. We'll spend more time on cardiac because that is more important. So once we finish the ECG and the basics, we'll finish the other three causes together. So percutaneous coronary intervention is, so as you know, the blood supply to the heart is mainly by three vessels. The main coronary artery divides into right coronary artery and the left main coronary artery, LMCA. Left main coronary artery divides into two. One is the left anterior descending, that's called LAD, and left circumflex artery, LCX. So I'm not going to tell you which part of the it supplies now. So just understand that the main coronary artery divides into right coronary artery, left main coronary artery. Left main coronary artery divides into left anterior descending and left circumflex. Just one thing which you have to remember is the right ventricle. So assume that this is the heart. Okay. So this will be the right ventricle. This is the interventricular septum. IVS, interventricular septum. So the right ventricle is supplied by the right coronary artery. The main left ventricle, anterior part of the left ventricle, is supplied by the left anterior descending artery. So this major part is supplied by LAD. So if you ask me which is the main vessel in the heart, it is LAD. And LAD is the most common vessel which is going to be affected by myocardial infarction. Okay, so most of the complications, the most common MI, most common vessel to be occluded will be left anterior descending. And when the LCX goes laterally, left circumflex goes laterally. So the lateral wall of the heart is supplied by LCX. Okay, so percutaneous coronary intervention is we are doing a coronary angiogram, finding out which vessel is blocked, which level is blocked, and we are trying to break this clot and keep it open by doing a stent. That is the aim of percutaneous coronary intervention. Since we are doing this directly, the treatment of choice for any ST elevation myocardial infarction will be PCI. But in some cases, suppose in low resource settings, because we need a cardiologist to do PCI, suppose if that is not available, what they tell is, once you diagnose MI, once a chest pain comes to your clinic, within 5 minutes, you are supposed to do an ECG and come to a diagnosis. Plus, the first thing which you have to give is the loading dose. Okay, chest pain comes, it's an anginal chest pain, you are doing an ECG, there is ST elevation in the ECG, you diagnose that. First thing you have to do is to give a loading dose. Loading dose is dispersible aspirin. Please remember the word dispersible aspirin because there's another thing called as ecospirin, entry-coated aspirin. Entry-coated aspirin is coated tablet, so it doesn't dissolve in the stomach. It will take time to get absorbed. So what we give is plain aspirin or dispersible aspirin. We call it as Dispirin. So Dispirin 325 milligram stat. Some give 375 also. Then we have clopidogrel. Clopidogrel 300 milligrams. So clopidogrel usually comes as 75 milligram tablet. We give 4 tablets of clopidogrel. And atorvastatin 80 milligram. So this combination is called as loading dose. So aspirin 325 milligram, clopidogrel 300 milligram, atorvastatin 80 milligram. So this is the first thing which you should give to any chest pain patient within 5 minutes, they come to your contact. Once you diagnose STEMI, the next thing is within 120 minutes, that is within 2 hours, or some say even it is within 90 minutes, you should send them to a PCA center. So within 90 minutes, they should reach a PCA center, and within 120 minutes, they should have done the stenting by that time. They say wire crossing. During coronary angiography, the wire crossing should be done within 120 minutes. That is the ideal setup. Suppose you are in a situation where you cannot ensure that the patient reaches a primary PCA center within 120 minutes, then what you can do is something called as pharmaco-invasive approach. So this is where you decide. So many people have the discussion. This is a STEMI. Will I opt for PCA or will I opt for a thrombolysis? So the best answer is PCA is, as per the current evidence, PCA is the best treatment modality available. So if you are able to refer the patient to a PCA-enabled center, that is the first thing which you have to do. Suppose you are not able to refer the patient to a primary PCA center within 120 minutes. For example, the patient is sick, or ambulance facility is not available, or the primary PCA center is far away. After giving loading dose, after trying to stabilize the patient, what you can do is you can do something called thrombolysis. So what is thrombolysis? We are giving some medicines intravenously to help the blood clot in the one of these coronary vessels lies. In PCA, what we are doing, we are just visualizing it directly and removing it manually. So PCA is by far the best, but thrombolysis is secondary treatment. But in situations where you cannot refer them to a PCA center, you can do thrombolysis first. Of course, PCA can be done even after thrombolysis. Okay, so even after a successful thrombolysis, you can refer the patient in an elective basis to these centers where they'll do a check angiogram to find out what is the percentage of block which is still there, and they can do a stenting to prevent another MI from coming. So that is called as pharmaco-invasive. We are giving medicines to lyse the clot first, and we are referring them to the center for invasive approach. This is called pharmaco-invasive approach. First one is a primary PCA, which is a definitive approach. Suppose there's another scenario where you are doing a thrombolysis first, it failed. Okay, so when do you say failed thrombolysis? ST, when do you say successful thrombolysis? ST elevation should come down by 50% from the first ECG in 2 hours, and patient's pain should have reduced. This is called successful thrombolysis. So suppose pain is still present, ST elevation doesn't come down by 50%, patient is still worsening, it's called failed thrombolysis. In that case, we have to refer the patient again as an emergency to a PCA center where they do something called as rescue PCA. In successful thrombolysis, electively for pharmaco-invasive approach, they can be sent for secondary PCA. So we have 3 PCA. Primary PCA is the preferred approach. In successful thrombolysis, in pharmaco-invasive approach, we can send them for secondary PCI. And in failed thrombolysis, what we do is rescue PCA. So understand these terms. So if one question someone asks you, the patients or patient attenders ask you which is the best treatment, it is primary PCA. If by any situation it is not possible, thrombolyze them and prefer them for pharmaco-invasive approach. So thrombolysis is a time-buying approach. So which are the drugs available for thrombolysis? So we give something called as thrombolytic agents. So one is streptokinase. It is an older drug only, but still in many low resource settings, in government setups, streptokinase is still the lifesaver. It costs, in private setup, it costs around just 2,000 to 4,000 rupees. So many patients who are not affordable for high-end treatments, they still go for the streptokinase. So just remember the dose. It is 15 lakh international units. It comes as a powder. So you have to mix that in 100 ml NS, 100 ml normal saline, 15 lakh international units to be given as infusion over 1 hour. So during this infusion, they should be monitored. BP should be monitored every 5 hours. The thing is, streptokinase is a drug which prevents blood clot and it lyses every clot which forms. So when the clot in the heart is lysing, there is also a possibility that patient may have some bleeding from anywhere. The dangerous minor bleeding can occur from hematuria. There can be oral mucosal bleeding or IV site bleeding, IV line site bleeding. So these are some minor complications, but one major complication of thrombolysis will be there can be bleeding from the brain. Intracranial hemorrhage is a small space, so even that can be life-threatening. So always before thrombolizing, this risk should be explained. We are doing everything to save the patient from going into heart failure or death, but there is always the chance that intracranial hemorrhage can occur. So this is how you give streptokinase. Then we have recombinant tissue plasminogen activator. They are the newer drugs or second line, like they are not second line drugs, second generation drugs. They are preferred now. So in order, it is altiplase, retiplase, and tenecteplase. So these are the second generation or the newer drugs which are available. Of course, they are costly. For example, altiplase 50 milligram cost around 45,000 rupees, I guess. So mostly everything comes from 38,000 to 60,000 coverage. Whereas streptokinase is still 2,000 to 4,000. So again, patients, they ask us. So one is 2,000, one is 50,000. Both have the same action. So what is basically the difference is, as I told you, streptokinase can cause ICH because of non-specific clot lysis. So there are two things which you have to see. One is the vessel patency, that is how effective is the thrombolysis to the coronary vessels, and another one is the selectivity, whether they cause bleeding in any other places. So I think the vessels 65% is the efficacy rate of thrombolysis, whereas selectivity is, I think it's 80% selective. I'm not sure of the actual values. So if this is the case, the recombinant tissue plasminogen activators are more effective. So the vessel patency rate will be 75 to 80% in case of tenecteplase. So the second generation drugs are more effective, and the chance of causing intracranial bleeding is less. So that is the difference why we prefer the second generation agents. So some medical colleges have these also available. I'll just quickly tell the dose. Altiplase comes in 50 milligram vials. So we have to dilute that. The first 5 milligrams should be given as IV bolus in bolus. Then the remaining 45 milligrams should be given as IV infusion over 1 hour. It's not 50 milligram. It is actually 0.9 milligram per kg. So for example, a 50 to 60 kg person, 50 milligram will be the dose required. For an 100 kg or 110 kg person, it will be 100 milligram. The first 10% of the dose, okay, 5 milligram is 10% of the dose should be given as IV bolus. The remaining 90% should be given as infusion. Retiplase is a fixed dose. Retiplase is not weight based, it is a fixed dose. So it should be given as 2 installments. So it comes in 2 bottles. The first 18 milligrams should be given stat. Give a 20 minutes break. Give the next 18 minutes as another stat dose. So this is how retiplase. Tenecteplase is also weight based, but it is not an infusion compared to streptokinase and altiplase. It is not two separate doses as in altiplase. It is just a one dose. That is why tenecteplase is very preferred. Why tenecteplase is preferred? It is one dose. Second, it has high vessel patency rate. As we just discussed, high vessel patency rate. It is highly selective, so the chance of intracranial bleeding is less. And another reason is it's easy to remember the dose. It's like 50% of your weight. For example, a 70 kg person, dose will be 35 units. 100 kg person, dose will be 50 units. So it comes as 35 and 50. It comes in various strengths. So roughly 50% of the dose will be 50% of the weight will be the dose. Okay, so we started our discussion of chest pain. I told you about anginal chest pain, typical angina, not atypical. we discussed about acute coronary syndrome, unstable angina, STEMI and NSTEMI. So we just discussed how to treat and how to approach them in an emergency. So we'll continue our discussion in the next part with ECG analysis about the enzymes and other causes.